All right, so I'm just going to tell you a bit about some of the imaging techniques that we have to study pain and what they've taught us about how pain is processed in the spinal cord and the brain. So the two big modalities that we have to study pain are PET, which is positron emission tomography, and MRI. So with PET, there's one radio tracer in particular that tells us a lot, and this is an opiate analog that has a radio ligand on it. And this collects in the brain, in the nervous system, it preferentially attaches to mu-opioid receptors. So in general, it shows us the distribution of these opioid receptors, and in pain studies, these tracers can actually be kicked off these receptors by endogenous opioids, so we can actually track the function of the endogenous opioidergic system by looking at decreases in this PET signal. But what we're more familiar with and what we tend to use more, at least in our lab, is functional MRI. And this is an MRI technique that tracks the changes in blood flow that occur in response to the greater metabolic demand of brain tissue as it becomes activated. And by looking at these changes in blood flow and how they correlate in time, we can determine that regions of brain that activate together in similar patterns are connected, or regions of brain that activate in correlation with a specific task are related to a certain function. And what we've learned from functional MRI is that pain is processed in a very, very complex way, and this has given rise to a theory called the pain matrix. So in this matrix, there are two ascending pathways and one descending pathway. So one ascending pathway, which is called the affective pathway, takes care of the emotional aspect of pain, which is how do you feel about this pain, how bothersome is it, and it's what makes you want to remove yourself from a painful situation. The other ascending pathway is the sensory and discriminative pathway of pain. And this takes care of, where is the pain located on my body, sort of from a more detached perspective, how severe is this pain, and the more non-emotional aspects of pain. But most interestingly for us is the descending pathway, which actually starts at the brain and descends down the spinal cord. And that involves nuclei in the midbrain, specifically one called the periaqueductal gray, and another way station in the rostroventromedial medulla, and these extend down to the spinal cord, where they actually can act on the first synapse where pain comes in from the periphery into the spinal cord, and this can actually inhibit further transmission of these painful stimuli. So this is a system that can actually prevent pain from even being transmitted from the brain in the first place. And or other groups actually have visualized the activity of this system in response to the placebo condition. But this activation they see in response to placebo is actually the same as the activation that occurs when you administer opiates. So it's really a very powerful system. In fact, in animals that have had electrodes implanted into the periaqueductal gray, stimulation of this site can produce such profound analgesia that it's rather gruesome, but they've actually performed surgeries on these animals with only this electrical stimulation with no signs of distress. So really what I want to leave you with is, I don't want to discourage anybody from studying or from looking at a solution that can patch into some of these imaging techniques like PET or fMRI, but I want to just remind you that the patient's internal context, sort of teaching them to recruit this intrinsic descending anti-nociceptive system can actually produce some very powerful effects. The context in which patients experience pain can have a very strong effect on the actual level of pain that they experience. So this could mean mindfulness training, leading patients through some mindfulness exercises, or some sort of neurofeedback to teach them how to better recruit this descending anti-nociceptive system. So, thank you.